All right, well, I'd like to first of all thank the chairs for kindly introducing me to the stage. I'd also like to thank Fertility Academy and IFFS for inviting me to Chennai today to speak on my topic, which is titled there on the first slide. So I have my usual disclosures. And just going through quickly the presentation outline for today's talk. I'll be first of all listing the factors that affect ART outcome. I'll then be talking about the hyper-responder, and that's someone who has a high ovarian response to standard or conventional ovarian stimulation, which is using FSH doses of about 150 to 225 international units, as defined by the ESHRA guidelines 2020, and it's also the most commonly used dose of FSH for ovarian stimulation in the general population. Then we're going to look at some evidence-based treatment strategies for the hyperresponder. We're going to look at how to first of all identify the hyperresponder with pre-ovarian stimulation strategies, and then we're going to talk about how to manage the hyperresponder in terms of ovarian stimulation and post-ovarian stimulation strategies listed there on the slide. And in terms of the evidence base for my presentation today, it is specific to hyperresponders. It does not include looking at the general population or normo-responders or poor responders, unless otherwise stated in my slide and presentation. And then we'll look at, follow up with a research agenda and some takeaway messages as a conclusion. So here are the factors that affect the outcome of ART, which I'm sure everyone here in the audience is well aware of. And today I will be specifically talking to those factors in red or pink font that are specific to the hyperresponder. So this slide shows a graph looking at the percentages of ovarian hyperstimulation syndrome and live birth per retrieved oocyte numbers per IVF cycle amongst SART members from 2008 to 2018. And this was published in 2014, and it shows quite clearly that as the oocyte numbers increase, then so does the percentage of live birth. And in fact, we see that live birth increases, then plateaus, and then starts decreasing with increasing numbers of eggs, and that the risk of ovarian hyperstimulation just continually increases. So we need to get that balance between efficacy and safety. This is a graph here of study by Polizos in 2018, which again, I'm not sure, is my microphone? Okay. Looking at the cumulative and fresh live birth rates according to the number of oocytes retrieved. And again, we can see that with increasing number of oocytes retrieved, with the purple bars here, the chance of fresh live birth rate increases, then plateaus and then reduces, but the cumulative live birth rate in the pink bars progressively increase. And this is the first systematic review on this topic, which we published in 2021. And it had 16 studies, and it looked at whether or not there's an optimal number of eggs retrieved at which live birth rates or cumulative live birth rates are maximised. And the key message from this publication was that 12 to 18 oocytes is the optimal range of oocytes retrieved to maximise live birth after fresh embryo transfer, and that there's a continuing positive association seems to be present between the number of oocytes retrieved and cumulative live birth rate. So we can define or diagnose hyperresponders either during ovarian stimulation, that's before egg collection, or after egg collection. And the, consensus from an IVF hyperresponder international expert consensus meeting published in 2023 this year, we came up with these numbers here to how to diagnose hyperresponders, and these numbers are based on the ESHRA guidelines for ovarian stimulation published in 2020, the ASRM guidelines published in 2016, and the ICMART consensus published in 2017. And hyperresponders are diagnosed by more than 18 to 20 follicles, at least 11 to 12 millimetres on the day of ovulatory trigger, and at least 18 to 20 eggs retrieved at the time of egg collection. So what are the concerns in hyperresponders? Well, first of all, there's a higher risk of ovarian hyperstimulation syndrome, and this is the most serious iatrogenic complication during ovarian stimulation, and it can be life-threatening, and its occurrence ranges from about 3% in normal responders to more than 30% in hyperresponders. There's also an increased risk of cycle cancellation prior to egg collection, and there's a missed opportunity to conceive in that cancelled cycle. There's increased costs as a result of this, and there's increased ART dropout, which can lead to a reduction in the cumulative live birth rate for the patients. There's also suboptimal live birth rates with fresh embryo transfer, as I've just shown before, that there's a reduction in the live birth rate per fresh cycle when you collect more than 18 to 20 eggs. And there's also an increased conversion of fresh embryo transfers to freeze-all approaches, and this can possibly increase cost. It can delay time to pregnancy, leading to live birth, and there's also differing obstetric and neonatal outcomes when you compare frozen embryo transfer to fresh embryo transfer. So treatment approaches prior to starting treatment for the predicted hyperresponder. Well, we need to make a clear distinction whether you're going to be aiming for a fresh embryo transfer or an elective frozen embryo transfer. Today, due to time restraints, I'm going to be talking about the former, where we're also going to be aiming for safety, so to reduce the risk of ovarian hyperstimulation, effectiveness, to optimise ovarian follicular stimulation, and so that there's no detrimental effect on clinical outcomes, and also to help reduce or prevent cycle cancellation, to reduce cost and reduce the risk of patient dropout. So what are the treatment strategies for the predicted hyperresponder where we're aiming for a fresh embryo transfer? Well, there's pre-ovarian stimulation strategies, there's ovarian stimulation strategies, and there's post-ovarian stimulation strategies. Looking at pre-ovarian stimulation strategies, we first of all can do a risk assessment to identify women at risk of high ovarian response. And so first of all, identify the potential hyperresponder, and then we can do that by looking at risk factors for high ovarian response, and this can be patient demographics such as young age, low BMI, polycystic ovary morphology on ultrasound, polycystic ovary syndrome. We can look at ovarian reserve markers such as high AMH antral follicle counts, or other markers such as basal FSH, estradiol, inhibin B. There can be dynamic testing, clomiphene citrate challenge test, and GnRH agonist tests. But AMH and antral follicle count are the most sensitive markers of ovarian reserve and can be considered interchangeable. And we can also look at the past history of high ovarian response to ovarian stimulation. Was there OHSS in a previous cycle? Was there cycle cancellation due to hyperresponse? Or was there coasting done? Moving on to ovarian stimulation strategies. These can include individualising the gonadotrophin starting dose, either by reducing the dose or using nomograms. We can use dose adjustment during ovarian stimulation. We can look at which is the best protocol to use, agonist or antagonist. Look at the types of ovulation triggering to use, and also consider alternative OHSS preventative measures such as coasting dopamine agonists or adjunct metformin. So individualisation or personalisation of gonadotropin starting dose in predicted hyperresponders is recommended rather than a standard ovarian stimulation of 150 to 225 international units as a one-size-fits-all. Now, ovarian response is dependent on the pool of recruitable follicles, that is the antral follicles, that can be then grown. There's real-world data from the USA of 23,000 women undergoing almost 34,000 ART cycles in 39 clinics between 2016 and 2019, which has shown that the mean start dose recombinant FSH in the general population is about 260 international units. Now, if we reduce the gonadotropin starting dose, which is recommended, then in predicted hyperresponders, this has been shown, the evidence has shown that this reduces the number of eggs collected, the risk of hyperresponse, the risk of OHSS, the risk of cancelling cycles due to hyperresponse, with similar efficacy, both in the first fresh cycle and cumulative live birth rates. The use of nomograms or algorithms using variables such as age, BMI, AMH, day 3 FSH, again, the evidence in hyperresponders has shown reduction in eggs collected. There's a reduced need to adjust the dose during ovarian stimulation. There's a reduced occurrence of increased occurrence of an adequate ovarian response, and there's reduced risk of cycle cancellation due to hyperresponse. And this is just an example of a nomogram here for calculating the FSH starting dose based on age and serum AMH. So we have the patient's AMH level, patient's age, which are aligned between the two, and then where it crosses the FSH starting dose, that's the number for the starting dose to use. Individualisation of gonadotropin starting dose is not always reflected in design of clinical studies, however. Example is the Megaset HR trial, published in 2020. This is an RCT looking at 620 women at risk of very high ovarian response. They had a mean age of 30, mean AMH of 7.7 nanograms per mil or 55 picomoles, mean antral follicle count of 31. And this study compared 150 international units of recombinant FSH with that of 150 units of highly purified HMG, and the results showed that HMG led to no evidence of a difference in ongoing pregnancy rate, but there was a reduction in OHSS. There was no evidence of difference in severe OHS. There was a reduction in cycle cancellation due to hyperresponse. There was a reduction in eggs collected, and there was no evidence of difference in cumulative live birth rate. But these results can be explained by not individualising the starting dose, because the starting dose was actually too high for the recombinant FSH, because it's been shown that recombinant FSH is actually more potent, has a higher bioactivity than highly purified HMG. There's been 6 RCTs in both normal and high responders comparing the same doses, either 150 or 225 of the recombinant FSH with the highly purified HMG, and have showed on average an extra 2 eggs with the recombinant FSH, and the start dose of the recombinant FSH in that trial should have actually been between 75 and 120 international units, and that's based on 3 available published nomograms. And there's also been an RCT compared 150 versus 100 IU of recombinant FSH in expected high responders, and it's shown that the 150 unit dose, there's an increased risk of hyperresponse, increased risk of cancellation due to hyperresponse with comparable live birth rates. How about gonadotropin dose adjustment during ovarian stimulation? Well, dose adjustment is common practice. It occurs in 40 to 50% of ART cycles, both clinical trials and real-world USA evidence. Dose reductions occur in about 9.5% of clinical trials and about 25% or a quarter of real-world data. It's more common in younger women, those with high ovarian reserve, those with ovulatory disorders and PCOS. Reducing the gonadotropin dose during ovarian stimulation specifically in hyperresponders has been shown to reduce the risk of OHSS and also all grades and also moderate to severe. Looking at GnRH analog protocol, the antagonist protocol is recommended in the predicted hyperresponder PCOS population to improve safety with equal efficacy, and that's recommended by the ESHRE guidelines on ovarian stimulation 220 and also the recently published International Evidence-Based Guidelines on PCOS published 223. The addition of clomiphene citrate or letrozole is not recommended. When we look at antagonist versus agonist long protocol in the general IVF population, no evidence of a difference in live birth rate, but there is a reduction in OHSS and reduction in cycle cancellation due to high risk of OHSS. When we look at the same comparison in the PCOS population, no evidence of a difference in pregnancy rates or eggs collected, but again, reduction in OHSS. So we can see the antagonist protocol is recommended. Now when we look at ovulation trigger in predicted hyperresponders, this is a busy slide, but let me take you through it. First of all, if using an agonist long protocol, then the recommendation by ESHRE guidelines is to reduce the HCG dose to improve safety, use 5,000 rather than 10,000. And in fact, HCG doses as low as 2,500 and 3,300 international units have been shown to effectively trigger oocyte maturation in ART without adversely affecting cycle outcome. So no difference in number of mature eggs, fertilisation rate, clinical pregnancy rate or OHSS. And the benefit of low-dose HCG trigger for preventing OHS is currently clear, and that's because the current published studies are few in number, so the data is sparse, and also there's small studies, small numbers of patients, small treatment cycles, and therefore they're just underpowered to be able to detect a difference in OHSS rate. But the antagonist protocol is recommended, and whether you're going to aim for a fresh embryo transfer or freeze-all is really an individualised decision between you and the patient. If you're going to go for freeze-all, then it's the agonist, GnRH agonist trigger is recommended by both the ESHRE and the PCOS guidelines, and that's based on evidence showing that the GnRH agonist trigger versus HCG trigger in women at high risk of ovarian hyperstimulation will reduce OHSS any grade and moderate to severe. If you're going for fresh embryo transfer, the ESHRE guidelines say it's clear whether to use a low-dose HCG trigger or a agonist trigger with luteal phase support with LH activity, and that's what we call modified luteal phase support. Whereas the IVF International expert consensus meeting paper actually recommends using the low-dose HCG trigger if there ends up being a normal response, but if there ends up being a hyper response, then to use the GnRH agonist trigger with the modified luteal phase support. And the ESHRE guidelines also recommend that using a GnRH agonist trigger with or without freezing is actually preferred over coasting. Alternative OHS preventive measures specifically in hyper-responder population, dopamine agonists have reduced OHSS without compromising live birth rate. Adjunct metformin in PCOS reduces OHSS in the long protocol, doesn't seem to reduce OHS in the antagonist protocol, and there's no evidence of a difference in live birth rates in that long protocol. And coasting versus no coasting, it's specifically in the hyper-responder population, reduces OHS without seeming to compromise live birth rate. And as I just mentioned, the ESHRE guidelines recommend a agonist trigger over coasting therapy. Moving on to post-ovarian stimulation strategies. The two strategies are either a freeze-all or doing a fresh embryo transfer with either intensified or modified luteal phase support when you use an agonist trigger, or a conventional or standard luteal phase support with a HCG trigger. Intensified luteal phase support is adding extra estrogen and progesterone to a standard or conventional luteal phase support, whereas modified luteal phase support is adding extra bolus of low-dose HCG, about 1,500 international units, on the day of egg collection to the standard or conventional luteal phase support. Now, post-ovarian stimulation strategy, in terms of what the response to ovarian stimulation. So we can see here if there is a normal response, then the ESHRA guidelines recommend HCG trigger, fresh T with conventional or standard luteal phase support. But if there is hyper-response, which I defined on my second or third slide earlier, then there are two options: freeze-all, fresh embryo transfer. This is the recommended strategy, is doing a freeze-all elective FET, and that's because that will reduce or eliminate the risk of late onset ovarian hyperstimulation. And the freeze-all versus fresh embryo transfer in the hyper-responder PCOS population has been shown actually, if you do that, there's an increased live birth rate in the first embryo transfer and reducing moderate to severe OHSS. But if the decision, for whatever reason, is made to do a fresh embryo transfer, then it's recommended to do a GnRH agonist trigger with either modified or luteal phase support. And when we look at the evidence for that specifically in hyperresponder population, here we can see when you compare a fresh embryo transfer with modified luteal phase support versus an agonist trigger freeze-all, no effect on efficacy, but there is an increased risk of moderate to severe OHSS with the modified luteal phase support rather than freeze-all. But when you look at fresh ET with modified luteal phase support versus a HCG trigger with the luteal phase support, no evidence of a difference with live birth rate, but there is a reduced risk of OHSS. And looking at the same with an intensified luteal phase support, fresh ET, versus the HCG trigger standard luteal phase support, there is no evidence of a difference in ongoing pregnancy rate, but again, it reduces the risk of OHS. So the agonist trigger, fresh embryo transfer, modified or intensified luteal phase support is safer than the HCG trigger using a standard conventional luteal phase support, but it's not as safe as doing an agonist trigger freeze-all. Moving on to where I think future research probably needs to be directed as to, first of all, is there an upper limit to the hyper-response in GnRH antagonist cycles where in the interest of safety, cycle cancellation should be considered rather than an agonist trigger followed by egg collection and freeze-all embryos and an elective later frozen embryo transfer cycle. And if so, based on how many number of follicles and estrogen levels, because currently the data that I was speaking to you about with the modified luteal phase support compared to the standard luteal phase support, even though there's been no evidence of a difference in the efficacy or clinical pregnancy rate, live birth rate outcomes, the confidence intervals have been really wide. And so it's uncertain. We can't exclude that actually one is better than the other in terms of efficacy. So we need more data on that. And also further adequately powered, well-designed, conducted RCTs are required to further assess the efficacy and safety of modified or intensified luteal phase support in the antagonist cycles for those reasons that I just mentioned. And we need really more trials with a head-to-head comparison of agonist trigger freeze-all elective frozen embryo transfer versus agonist trigger modified luteal phase support. Again, for those reasons I just mentioned. So in conclusion, first of all, the sweet spot for maximal live birth rate following a fresh embryo transfer is between 12 and 18 oocytes retrieved. AMH and antral follicle count are the most sensitive markers of ovarian reserve to predict ovarian response. And looking at this table, when we're looking at the strategies versus safety in terms of OHSS, efficacy in terms of pregnancy rate, live birth rate, we can see that individualised gonadotrophin starting dose either through lowering the dose, nomograms will improve safety, no effect on efficacy. Reducing the gonadotrophin dose during ovarian stimulation, it will improve safety, uncertain whether its effect on efficacy. Using a GnRH agonist protocol will increase safety without affecting efficacy. Using an antagonist protocol with hyperresponse and then using a GnRH agonist freeze all will improve both safety and efficacy. If you have an antagonist protocol with hyperresponse and you're aiming for a fresh embryo transfer and you use modified luteal phase support, then that will reduce safety compared to a freeze-all, but it will increase safety compared to standard luteal phase support without affecting efficacy. Looking at a GnRH antagonist protocol with hyper-response and using a lower dose HCG freeze-all improves safety and also improves efficacy. The use of dopamine agonists will improve safety without affecting efficacy, as will adjunct metformin in PCOS women with the long protocol, and as will coasting. But remember that the GnRH agonist trigger is preferred rather than coasting. And I'd just like to finish by saying that I highly recommend reading this paper, and this is the Hyperresponder IVF International Expert Consensus Meeting paper that was just recently published this year. And thank you very much for listening.